A very good afternoon to everyone and welcome to session 2 of the course. It's so exciting to see everyone, the participants joining from across the country, from all levels of healthcare. So I'm so glad that people are joining from the National Referral Hospital, but not only from the National Referral Hospital, but also from the district hospitals and even from the primary healthcare centers. So welcome everyone and so good to see you all. So as Sangeet mentioned, the session today is on pain assessment and management. There's a slight change on the topic. We changed it from pain and constipation to, we actually renamed the topic. It's now pain assessment and management. And for this session, we will have 3 presentations. We will start with a 20-minute presentation on pain assessment by Professor Melanie Lovell. And then Professor Odette will do another 20 minutes of presentation on pain management. And the last presentation will be a case presentation by Sister Youngden, the lead of home palliative care at the National Referral Hospital. And Sister Youngden will do the presentation for 15 minutes. And we are expecting lots of question answers session. We are expecting lots of discussion to happen after the presentation. So please keep posting your questions using the chat box, or you may also ask questions yourself after each presentation or at the end of 3 presentations. Okay. So to introduce today's presenters, Professor Melanie Lovell is a palliative medicine physician, senior staff specialist with Hemon Care in Northern Sydney. Melanie is a senior academic in the Palliative Care Centre, clinical associate professor with University of Sydney and adjunct professor with University of Technology, Sydney. Melanie's research interests are in cancer pain and health service research. She was founding chair of the Cancer Council Australia's Pain Management in Adults Guideline. And currently, Melanie is the chair of the Pain Node of Palliative Care Clinical Studies Collaborative and Cancer Symptom Trials Group, which conducts trials across the spectrum of research methodologies and translation. And you know Professor Odette already, right? And Sister Youngden leads the home-based palliative care program at the National Referral Hospital in Thimphu. In 2018, after having spent almost 20 years in nursing and midwifery, she was appointed to start and lead the country's first palliative care service. With limited resources and without even having an office, Youngden took on the challenge to establish the home palliative care service for patients living in Thimphu. Within the last 5 years as the lead in home palliative care service, Youngden proposed to introduce palliative care service at the National Referral Hospital. She prepared the report highlighting the successes of the home care pilot project, which she presented to the Ministry of Health. She also developed a national palliative care training manual for Bhutanese healthcare professionals with guidance from WHO CRO. Youngden envisions growing the home-based palliative care program into a palliative care department with a multidisciplinary team and specialist trainings. She strives to provide her patients and their families with the best possible support and compassionate care. Youngden is also a proud mother of 3 children. And with that, I would now like to hand over the floor to Melanie. Thank you, Melanie, and welcome everyone.
Thank you, Tara, and I'd like to add my welcome to everyone and say what a joy it is to join you. I'm joining from Sydney, where it's 30 degrees and a very different setting to the one that I imagine most of you are in. I'm going to share my slides. Can you see those okay?
Yes, ma'am, it is visible.
Okay. All right, thank you for the very kind and warm introduction, Tara. Much appreciated. So as I say, joining you from Sydney, where we have our harbour and opera house, and no mountains apart from in Greater Sydney. Tara did a really important piece of work in 2021 where she looked at the palliative care needs of the population. And this was a group who were in the last weeks of life. They were at the major centres as well as the district hospitals and then in the community. Today we're going to talk about pain. And in the population that Tara studied, there were 70 people, 29 had cancer and 41 had other diagnoses. And you can see that the people with cancer had a score of around about a median score of 55. So really moderate pain as a median score. Those who had other diagnoses had 39.8 on a 0 to 100 scale. And the mean of the whole population was 46.2. So you can see that pain was a significant problem for this population. You can also note that, in fact, there was lots of symptoms. There was a high symptom burden amongst the population. We'll talk a little bit about how they can interact with each other. I wanted to introduce you to this clinical pathway for screening, assessment and management of cancer pain in adults. It's the Australian guideline, which is on that web address you can see below there. Today in the talk I'm going to present, we'll be talking about screening, comprehensive assessment, communication, and some self-management strategies, including some non-pharmacological strategies. And Odette will go on and speak about pharmacological and other treatments to manage cancer pain. The first step of the pathway is screening, and this is how we determine whether or not someone has pain and how severe it is. There are a number of ways of doing this. It can be done with a numeric rating scale looking at severity, and I hope you can see at the bottom here, this is the Edmonton Symptom Assessment Scale, where people rate their pain from 0, which is no pain, to 10, which is the worst possible pain. There are other scales that you can use. This up here is a symptom assessment scale, which actually looks at how much the pain distresses or bothers you. Again, there's a 0 to 10 scale. A significant proportion of people will not be able to use a numerical pain rating scale. It will be something that they find difficult to understand. And there are other options. There's a faces scale where people can look and see, okay, here I'm smiling, there's no pain, here starting to get uncomfortable, and here really with severe pain. And that's a good thing to use for children or for people who have low literacy levels. There's also categorical scales where pain is absent, mild, moderate, and severe. And the descriptors will vary depending on culture and language. Those descriptors are very common in the literature, but in your populations and in the different language groups with which you work, it may be that other descriptors are most helpful. And so each person needs to have an individualised pain assessment so they can communicate the degree of pain they have. A helpful way of describing the degree of pain is a interference scale. The brief pain inventory is one such scale, and we'll look at that in detail shortly. For people who are cognitively impaired, who are unable to communicate their level of pain, there are a number of scales where you can look at observable behaviours. This is one such scale. There are others. And you can see that it's categorised in terms of vocalisation. So if people are calling out, groaning, whimpering, that sort of thing. The facial expression, very similar to the faces scale. Changes in body language, people who are holding a part of their body, they're fidgeting, rocking, or withdrawn. Behavioural change, it may be that people are increasingly confused or refusing to eat. And in people who have disturbed behaviours on a background of dementia, a very high proportion of them will actually be having pain that's causing those disturbed behaviours. There may be physiological change or physical changes where you can actually see something that's very likely to be a source of pain, such as a skin tear or a bruise, contractures, pressure areas. that sort of thing. This is the brief pain inventory, which looks at the impact of pain on elements of the activities of daily living. And so you can see here it's a scale 0, there's no interference with that particular activity, or 10 completely interferes. It might be the general activity, the mood. Pain can have a big impact on mood, and mood can have a big impact on pain. Walking ability, so people may be in such severe pain that they cannot walk. Normal work, and that includes work inside and outside of the home. Relationships with other people. People may be in such degree of pain that they aren't able to relate in their normal way with family members, friends, or in the workplace. Sleep, people may be woken from sleep. And that can be because of the pain itself, but it also may be that they actually can't get into a comfortable position because of where the pain is. And enjoyment of life. A pain chart can be very helpful to just allow people to point to where on their body they feel pain on the chart, and a significant proportion of people will have multiple pains, and it allows them to highlight the various parts of the body where they might have pain. So why do we screen? There's good evidence that screening for pain improves the reporting of unmet needs. And as I mentioned at the beginning, assessing pain, as Tara did in that important piece of work in Bhutan, she was able to identify really high levels of need across that population which she surveyed. It also results in improved quality of life. I'm going to go on now and talk about assessment. In terms of assessment, a good assessment will make a big difference to the pain management. And there's quite nice data that actually improving pain assessment and improving training in pain assessment for the range of health disciplines can improve pain outcomes for patients. So what are our goals as we're assessing pain? We want to know what's causing the pain. This is actually on the diagram here, what's described as the noxious stimulus. What is actually causing the pain? Is it a cancer pressing on a nerve or a bone? Is it that there's a clot in the leg? Is there infection that's causing inflammation, redness, heat, and pain? We want to determine the modulating factors. Now, this is about the things that are interacting with the pain to increase the pain experience. And in this diagram, we've called it raising the threshold. What are the threshold issues that are making the pain worse? We'll look at these in some detail shortly, but they're the sorts of things that may be psychological, such as depression or anxiety. They may be spiritual, such as fears of God or spirits. They may be cultural and social. And addressing those will be key in order to get pain control. And it's very unlikely to get good pain control unless those factors are addressed. And then the final thing we're looking at when we're assessing pain is what is the mechanism of the pain? So we've looked at what the cause is and what's making the pain worse. We're now thinking about actually what's happening at a physiological level. Is it a neuropathic pain? Is it a nociceptive pain? Or is it mixed? And that will help direct the treatments that we use. Once we've started some treatment, we then assess the response to treatment. So we go back and redo our assessment. I want to talk about some of the factors now that impact that we need to think about when we're talking about pain experience, which will help us determine the cause. Sometimes it's helpful to use a mnemonic, which is a set of triggers to help us think about the different aspects of an item. We sometimes use PQRST. There's several of them for pain. P standing for what are the precipitating and relieving factors of the pain. For instance, is someone getting pain when they're walking? Are they getting pain when they're lying flat? Is the pain relieved by heat? Is it relieved by sitting forward? Is it relieved by rest? Is it relieved by morphine? What is the quality of the pain? And we'll go through some of the different pain descriptors shortly. that will help us understand whether or not it's nociceptive or neuropathic pain. And what is the impact on the quality of life? That will help us understand how much the pain's interfering, and also give us a sense for where the person is in their illness trajectory. Where does the pain radiate to? Again, that will help us determine the cause and mechanism. What's the site of the pain? And what's the timing? And this is really key. If someone's had pain for 10 years, we've got quite a different approach from someone who's got an acute pain that they've had for just a few hours or days. And our approach is going to be different. How long does each episode last? And what tends to be the things that start the episode and finish the episode? Cicely Saunders was one of the founding pioneers of palliative medicine, and she described this idea of total pain. And what this does is help us think about the many aspects that can impact on the pain experience. So there's the physical aspects that we've talked about. And then there's the range of threshold issues, which is all the other things, psychological, spiritual, and social. Someone may be very afraid, and often when people have pain, they may not understand what's causing it. They may fear that it's going to get worse. They may be quite overwhelmed by it. So those aspects of care are key to getting it under control. They may have had past bad experiences with pain management. Spiritual is really important, and I was so interested in Tara's article where she talked about some of the meanings of pain for people, which may be that there's a bad or a vengeful spirit causing imbalances in that body. And until actually that particular concern for that person is addressed by traditional healers or spiritual advisors, it's going to be very hard to get the pain under control. Social issues are very important. Financial concerns in being able to afford pain medicines, loss of role and status, loss of job, and worries about the future. So this is why we need a multidisciplinary team to address pain, because a doctor or a nurse won't be able to manage all these things. A pharmacist, physiotherapist, social worker, assistants, and other health professionals need to be involved for optimal management of complex pain. The other elements to think about are current and previous management of pain, including traditional healing, a physical examination, and where needed, further investigations. There are some risk factors for poorly controlled pain, which includes things like the very elderly, the very young, people who have previous substance use disorder. And I'm afraid I don't know how common that is in your country, but people who have substance abuse disorders are often at risk of poor pain management because their pain needs are not seen as valid. Family needs and preferences, and this is the goals and expectations around both the disease but also the pain management. Importantly, we do need to think about whether there's, for people with cancer, an emergency. Is the back pain related to a spinal cord compression? Is the headache related to a increase in intracranial pressure? So those are factors that we also need to assess. The descriptors that are often used for nociceptive pain are aching, stabbing, throbbing, squeezing, or gnawing. For people with neuropathic pain, they may describe it as burning or shooting, tingling. There may be associated numbness in the area of the pain or weakness, and it may be associated with allodynia. This is where a normal touch feels painful, or hyperalgesia, where a painful touch feels excessively painful compared to what you would expect. So they're the elements about pain assessment I wanted to talk about. And now just a few minutes on the pain, some pain self-management. Once someone understands what the cause of the pain is, that's going to make a big difference. I'll mention patient education in a moment. There are lots of strategies that people can use at home. For instance, positioning. So a physiotherapist can assist with positioning that can be very pain relieving, or an occupational therapist. There can be mindfulness, meditation, relaxation and breathing exercises that can make a big difference and reduce the requirement for strong pain relievers. I'll show you one example of a pain diary, but a pain diary is one way of people recording when they get the pain, how bad it is, what seemed to trigger it and what relieved it, and anything else related to it. And that can help people get a sense of understanding and start to see patterns which can help advise about pain management. Actually, writing a pain management plan with your patient can make a really big difference to their ability to manage the pain. Now, that doesn't have to be a written plan because, again, you know, for patients who have low literacy levels, that's not going to be of great assistance to them. But it might be as simple as putting the medicines in a pack and indicating very, very clearly what to take when. Developing that with your patient will improve their adherence because they're more likely to understand when, how, and why to take the pain management. And finally, goal setting. What are we looking for here as we start pain management? Are we aiming for people to be able to sleep better? Are we aiming for people to improve their function so they can help with the children at home, for instance? In terms of pain education, as I mentioned, if people understand pain a little bit more, then it reduces the fear and improves pain outcomes. In some clinical trials, it's been as effective as medications with very, very little harm. In the education, it needs to be individually tailored to a person's concerns. If a person, for instance, is concerned about being addicted to strong pain relievers such as morphine, then addressing that concern can improve adherence and they may well take that medication. If these medications are used appropriately for acute pain and pain at the end of life, then there's no risk of becoming addicted. The small group of patients in whom this is a problem is people who've previously had opioid or other substance abuse issues, and that's something that needs to be kept in mind but shouldn't prevent them from having adequate pain control. Other potential myths are things like starting morphine means I'm dying, and we know that morphine can be used very effectively and does not reduce lifespan. Side effects do exist, particularly constipation, but they can be managed. And this is a pain diary. Sorry, it's a little bit hard to see the small writing here, but the idea, the date and time, the description of the pain score, what made it worse, and what helped you with it, and any other comments you might want to make. Really, there's many ways of doing a pain diary. It might be as simple as a piece of paper with a tick I had, a tick I had pain, or a cross I had no pain, for instance. And then the final thing, this is just an example of a pain management plan, a written one where people can write what their regular pain relief is, what the breakthrough medication is, so what to take if the pain gets worse between the regular doses, what the laxative plan is, so what people are using to prevent constipation and other adverse event management, non-medicinal pain management, and when to seek help, who to contact, and who it was discussed with. We're coming to the end of my time. I'll stop sharing my screen there. And back to you, Tara.
Thank you, Melanie. Thank you so much for taking us through all this. I think before we proceed further, there's a question in the chat box. Bhim Kumar, he says, which pain assessment tool or scale is recommended for the patients who are in the ventilator, basically intubated patients? So Melanie, if you can help us.
Yeah, that's a really great question. And I did notice that there were people joining from ICU, and I apologise for not addressing that as I went through. Intubated patients are not going to be able to speak to you. So it'll be a behavioural sort of tool, someone who's starting to look distressed and agitated. It may well be having pain. If their pulse rate and blood pressure are going up, may well be an indicator of pain. So it's more the observational things rather than a history that's going to help you with that.
Thank you. Is there any other question from the participants that you want to ask to Melanie now, or you may also do it later? There are some messages. I'll just have a look.
Yep, is fentanyl patch safe to use for palliative patients if morphine doesn't work? Yeah, great question. Thank you so much. And I'm sure Odette will also be addressing. Fentanyl is safe for people who have previously been on morphine. Even the lowest patch is equivalent to quite high doses of morphine. And the other thing about it is that it's not as able to be, the dose isn't able to be quickly changed because it's a 72-hourly patch. It takes about 24 hours or so to switch. So yes, it's safe in people who've previously been on some morphine, and it may be very, it can be cautiously titrated. Good question.
I know, very important questions. Thank you. And also when you mentioned about how it is in Bhutan when we handle patients with the history of substance abuse, well, I do remember that most of us feared prescribing pain medications to patients who had a history of having used substances because we felt it would be more harmful giving a pain medications and rather let him be in pain instead of, really seriously considering a use of opioids, especially to reduce his or her pain. So I could think of that. And also, I also remembered when you mentioned education, how important it is to educate families, because I had a cancer patient who was in severe pain, and the doctor had advised morphine, but the family members were already prepared that they're not going to use morphine for now because they thought morphine means end of life, and she's not yet there to start morphine. So this is very important that we share and learn from how we assume and not be able to help patients the way
what a good example. That's exactly the sort of example and the reasons it's important to address. And thank you for highlighting that it's actually educating the family as well as the patient.
Thank you, Melanie. Thank you so much. And we do expect questions. What is the real risk of addiction with opioids? There's a question there. What is the real risk of addiction with opioids?
Yeah, it's a really great question. If someone is using opioids for acute pain or pain at the end of life, there's very, very little risk of addiction. For people who are using morphine chronically over a long period, then there's a risk of dependence, but that's very different from addiction. Addiction is when people are using morphine or other opioids in order to have effects on the body that aren't related to pain. So they're using it for, for drowsiness or for escapism or other types of coping. Because people are dependent doesn't mean that they're addicted. It does mean that a dose would need to be reduced very, very slowly or increased. In terms of using morphine for longer periods of time, I'm not sure if Odette's going to address this, but the evidence for it isn't strong. And I would be thinking about as many non-pharmacological strategies as possible, as well as other adjuvants such as the antineuropathic agents and so on, if people are going to be on these agents for a very, very long time. There's another question there. Is it safe to use paracetamol with morphine too, e.g. for gallbladder cancer patients? Absolutely, it is safe. And the evidence for them together isn't terribly strong, but I would be trying it because people, a number of people do respond to it. With all these things, if you trial a medication and it's not actually achieving the goals that you and the patient have set for the medication, then you can feel free to stop them.
Yeah, thank you so much, Melanie. And now I would like to invite Professor Odette for pain management.
Thank you, Tara. Thank you, Melanie. Could you put the slide on, please, Sangeet? I mean, Melanie's given such a great introduction to pain assessment, and you can see actually that assessment goes a long way towards management because it engages the patient in understanding their own pain as well. When we form that relationship with patients in order to assess their pain, and as I learned right in my early days in palliative medicine training, pain management occurs in the context of relationship. So that process of assessment, understanding the pain, understanding what it means to that patient is such an important part actually of pain management. And I'm so glad, Melanie, you mentioned something about the myths that we need to address, because that is also, and Tara, you also mentioned that about the fear of opioids being just for end of life or being addictive, because they also impact greatly on a patient's willingness to come on this journey with us as we try to work with them in managing their pain. Can we have the next slide, please? I'm going to talk really about managing cancer pain, because talking about non-cancer pain, chronic pain, really is such a big area in itself. Many of the principles are the same, but the use of opioids, as Melanie's already mentioned, is a little different. So we should always start with non-pharmacological strategies and self-management strategies. There's strong evidence that they impact and improve the outcomes in pain management. There's less evidence for some of the other non-pharmacological approaches. However, lack of evidence doesn't mean lack of effect. It's not easy to get good, strong evidence in pain management, and many of the studies and the evidence that we have tends to be more in the pharmacological zone, because I guess that's where some of the studies can be conducted, because there's pharmaceutical company backing for those studies. So I just think it's important to stress that if a patient finds non-pharmacological approaches such as music therapy, massage, meditation helpful, then of course that should be encouraged. Next slide, please. Now, many of you may be familiar with this tried and true concept of the WHO analgesic ladder, which came from work done by an expert group convened by WHO. I think around the 1960s was the first edition of this ladder, and it's undergone a number of changes and additions, and this is a relatively newer version of the same thing. But essentially, the ladder refers to the what we do about increasingly severe pain, how we approach that. So from step one, so the ladder refers specifically to the intensity of the pain and the appropriate matching intensity of analgesia. So you can see step one, we generally use non-opioids and such as paracetamol and non-steroidals. Step two, you may add in weak opioids. step 3, you substitute the weak opioid for a so-called strong opioid. And at each of those steps, you may continue the non-steroidal and or the paracetamol. But as Melanie said, if the patient isn't getting benefit from the paracetamol, or if there are reasons not to use a non-steroidal, then you can withdraw those agents. And we have to always be mindful of the medication burden that many of our patients with cancer have. And so we're always trying to rationalize their medications. But also it's important to recognize there are other strategies such as the interventions, nerve blocks and epidurals, and more highly interventional approaches that usually are reserved for patients who have difficult to manage pain, but sometimes may be used at an earlier stage. For example, celiac plexus blocks for patients with pancreatic cancer may be given early on in the course of that condition, rather than waiting for the cancer to become and the pain to become more advanced, because of people do get benefit. Next slide. In addition to the ladder itself, this focus on the intensity of pain and the medications for increasing severe pain, the WHO group also talked about these other principles for cancer pain management. So we recognize that with cancer pain, pain is often constant. It's not like an acute injury, we fall over, we hurt our leg, we have pain for a few hours or maybe a day or so, and then it goes. And so we just take 1 or 2 doses of an analgesic, some paracetamol, some non-steroidal. The pain's over, we don't need to continue. With cancer pain, there's, for metastatic disease, for chronic, for bony pain, for many types of cancer pain, the pain is continuous. And so the principle here is that we should also have continuous analgesia, and that's what by the clock means. So we're using the medication according to its pharmacology and its duration of action. So that means that's the clock. And we encourage patients to take their analgesia regularly and to stay on top of their pain, rather than to wait for the pain to recur and then take their analgesia. So there's this sort of concept of covering the pain, if you like, with a constant dose of analgesia. By the mouth means that the patient can be treated at home, it's less invasive, it gives the patient control, there's no need to be giving analgesia by injection unless the patient reaches a stage where they're unable to swallow. By the ladder, and then this idea of attention to detail, and that goes back to Melanie's talk about understanding the cause of the pain, both in terms of what sort of cancer process perhaps, but also in terms of the physiology of the pain. Is it nociceptive? Is it neuropathic? And also for the individual patient. Every patient may respond differently to the analgesics. They have other drugs that are unique to them. And so we have to tailor the treatment for the patient. And then the principle of reviewing, assessing and reviewing and adjusting. Next slide, please. In Bhutan, you have an essential medicines list, and this was just updated last year. So you have a section there, medicines for pain and palliative care, and you've got a reasonable range of non-steroidals. You have paracetamol in syrup and injection and in tablet and suppository, and in tablet form. And you have, in terms of opioids, codeine at 15 milligrams. You have a fentanyl patch at 50 micrograms, and you have a range of morphine. You have a 10 milligram immediate release tablet, 15 milligrams extended release, injectable morphine, You have pethidine and you have tramadol, which would be classified as injection, which would be classified as a weak opioid. And you also have medicines that are used in neuropathic pain, such as amitriptyline, an antidepressant, and carbamazepine and gabapentin, which are both anticonvulsants. So you have the building blocks of good pain control. And in addition to that, I was looking through your list, and you have other agents such as sodium valproate, baclofen, which can be used for cramping pains. You have dexamethasone, you have ketamine, and you have lignocaine. So you don't have a large selection of opioid analgesics, but you have the essential, which we would still say is the gold standard, which is morphine. So I think you have a good working list here. Next slide, please. So we're going to just work through some of the agents, just as a refresher for many of you. I'm sure you are familiar with this. For paracetamol, somebody's already asked a question about paracetamol. So just to reiterate that it is a useful agent in cancer pain management, can be used in conjunction with the opioids, although there is a lack of evidence for effect with strong opioids. However, it may be useful and for some patients. And it can be used at a reduced dose for patients with chronic liver disease. Next slide. The nonsteroidals are an important group of analgesics. Unfortunately, because of their side effects, we find their use in cancer pain management often is limited. As you know, nonsteroidals inhibit the synthesis of prostaglandins by the cyclooxygenase enzymes, the COX enzymes. Prostaglandins are critical mediators of inflammation, fever, and pain, but they also maintain renal function, the gastroesophageal mucosa, and also are very important for platelet activity. There are so-called selective COX-2 nonsteroidals. Celecoxib and paracoxib are two that are examples, and non-selective nonsteroidals. As far as I could see, Bhutan has non-selective nonsteroidals only, and you have a good range of those: diclofenac, ibuprofen, indomethacin, etc. Next slide. So the adverse effects of nonsteroidals, I think, will be known to most of you. Importantly, gastric, and these match the sites of action, of course, of the nonsteroidals on the mucosa of the stomach and the esophagus, so you can get irritation. It is less with COX-2 selective inhibitor nonsteroidals. You can get renal toxicity, and there's no protection with the COX-2 selective. So renal toxicity occurs with all nonsteroidals, potentially. And then impact on platelet adhesion. Now, COX-2 selectives don't inhibit platelet adhesion, but they may actually go the opposite way and promote thrombotic events. So the impression is that COX-2 selective nonsteroidals have their problems and are not. I think not having them is not a major problem for Bhutan. Next slide, please. So in general recommendations for the use of nonsteroidals would be to use gastroprophylaxis routinely. So some sort of gastric acid reducing or gastroprotective medications, such as omeprazole or something along that class of drugs, to take the nonsteroidal after food and to maintain good hydration, and not to exceed the dose. Sometimes people are not aware of the potential toxicity of these agents. Ibuprofen at doses less than 400 milligrams 3 times a day is probably safest. Diclofenac does have reported higher cardiac morbidity. And if you had COX-2, the advice would be to selective COX-2 non-steroidals would be to use them only for short term to reduce thrombotic and cardiac risks. Next slide, please. Weak opioids, we have codeine. This is regarded as a prodrug as it's metabolized to morphine. It's renally excreted. You can use up to a maximum of 360 milligrams a day, but we would seldom use that dose. Main indications are for pain, cough, and diarrhea control for short term. Major adverse effect with codeine, which seems to be a little out of proportion to its pain relief benefit, is constipation. And some people would say that if you do have access to morphine and other strong opioids, that you don't really need to use the weak opioids because you can use the strong opioids at lower dose and perhaps have better pain relief with less constipation side effect, if that makes sense. Next slide. Tramadol is the other weak opioid that you have on your medication list. It's also a mu-opioid receptor agonist, which is where all the opioids act in the nervous system. But it has additional action on noradrenaline and serotonin receptors. It's a reuptake inhibitor, and that has a kind of additional benefit of inhibiting pain transmission in those pathways. And I must admit, I do at times find it to be a useful drug for cancer bone pain. You have to be careful using tramadol with other drugs that have impacts on the serotonergic system. You may precipitate a serotonin syndrome if you have that combination, and to avoid using tramadol when a patient may be on the antidepressant class of drugs, the monoamine oxidase inhibitors. Next slide. Now we need to race through some of the opioids. There are a number of different opioid classes, and morphine is kind of the prototype of one class. Fentanyl belongs in another, and methadone in the other. So let's look at morphine in some detail. Next slide. It's still regarded as the gold standard opioid, and in a lot of the literature, there's this metric called the morphine equivalent daily dose, where other opioids are converted to a morphine equivalent dose, just to provide a common sort of language to get across the opioids. Now, morphine acts at the mu receptors, particularly in the midbrain, and that's where the opioid-induced analgesia comes from. It's metabolized to M3G and M6G, and it's the M3G that accumulates in renal failure or renal impairment and can lead to delirium or even seizures. Morphine is as you've seen on your formulary, comes in a variety of administration routes: oral, extended release, immediate release, tablets, liquid, and injectable forms. And it can be also given intrathecally. So that's one of its big advantages. If you're converting from an oral dose to an injectable dose, I use a 3:1. Some people use a 2:1 ratio. So 3:1 would be 30 milligrams oral equals 10 milligrams subcut. And we tend to use the subcutaneous route in palliative care practice rather than the IV route, just because it's much less onerous for the patients and for nursing and for healthcare staff to maintain that route. Next slide. I thought I'd take you through some of the steps around prescribing morphine. So if a patient is actually opioid naive, hasn't been on any weak opioid or other opioid, then a safe starting dose for an adult would be 5 milligrams immediate release morphine 4 hourly. Now, if it's it could also be 10 milligrams 4 hourly, but 5 milligrams is probably a safe starting point. Or you could use 15 milligrams extended release 12 hourly. And then because we need to allow for not only the constant pain, but episodes where pain so-called breaks through the regular dose of opioid, we usually advise also allowing the patient to take an extra dose of the immediate release, even as frequently as 1 hourly, to top up their regular dose. I'll go into this a little bit more. And always prescribe a laxative with the opioid. Next slide. Constipation is almost a universal side effect of opioids. In addition to laxatives, think about making sure the patient's well hydrated. Look at the other drugs that may also be contributing to constipation and see what perhaps could be removed. Inmobility certainly adds to constipation. Bowel obstruction is a potential problem that you need to be looking for. And also just the weakness that comes with progressive disease and the muscle wasting, or even around pelvic muscles, can also contribute to constipation. So we do remember the maxim, the hand that writes the opioid must also write the laxative. And I think in Bhutan, I saw that you have senna and lactulose. I'm not sure if you have the macrogel. And you also have glycerine suppositories, and perhaps you have your fleet enema, or I'm not sure what enemas you have available. There's also a new class of drug called the opioid antagonist, the mu2 antagonists, that work just on the gut level and don't antagonize the opioid effect in the nervous system. So we have a drug called methyl naltrexone, which can be used to reverse severe opioid-related constipation. Next slide. Other side effects are nausea, drowsiness, itch, myoclonus, which is not necessarily toxicity, but can be quite a distressing side effect. Pinpoint pupils, which are common in a normal opioid effect, doesn't indicate toxicity. It's a parasympathetic effect of opioids on the muscles of the iris. Some people do have a genuine allergy, but often what's said to be an allergy is really just nausea that is quite common when you first start an opioid for the first week or so. And respiratory depression really is a sign of overdose rather than just a side effect of opioids. And there are often other predisposing factors such as unrecognized worsening of renal function. Next slide. Now, how to titrate. So we've talked about a starting dose. What we often do, there are two kind of methods. The first is, if you like, the breakthrough method. So if you've given the patient freedom to use additional doses of breakthrough over and above their regular dose, then 24 hours later, you can sum up the total dose of opioid, the regular plus the breakthrough dose. You divide that by 2 for the 12-hourly dose. So, for example, if they were on 45 milligrams twice a day regularly, and they used another 30 milligrams breakthrough, the total 24-hour dose then was 120 milligrams. Divide that by 2, and their new regular dose is 60 milligrams twice a day. So if the patient understands what they're doing with the breakthroughs, and you trust the reason that you are confident with the way they're using the breakthrough, and you feel that they're getting good result with the breakthrough, then that's a good, safe way of doing it. Some patients are very reluctant to use the breakthroughs, and so you'll underestimate what their pain requirement is if you use this technique. And as you increase the 24-hour dose in the regular dose, you usually need to adjust the breakthrough dose as well. And we sort of use roughly between a sixth to a tenth of the 24-hour dose to give us an indication of what an effective breakthrough dose would be. Next slide. The other method is the percentage method, where you can safely increase the opioid dose by 30 to 50% of the previous 24-hour dose. So if again, 45 milligrams twice a day, 90 milligrams, patients still reporting significant pain, maybe pain more than 4 out of 10 on average over the previous day. 30% of 90 milligrams is 30 milligrams. So you add that to your 90 and you get 120 milligrams for the 24 hours. So you come up with more or less the same dose. So this way sometimes is better when you feel that the patient perhaps is underreporting their pain for whatever complex reason there may be. And that goes back to some of the assessment that Melanie was talking about before. Some people are frightened to acknowledge their pain because it's an indication of, it's a fearful thing. It maybe indicates their cancer is progressing or whatever reason. But next slide, please. So ceasing opioids, sometimes when a patient's had radiotherapy or surgery or some treatment that has really alleviated the source of their pain, it's possible to reduce or even cease their opioids. Even in treating cancer pain, we sometimes find we can do this. It's important to note that physical dependence and tolerance can develop with prolonged use. It's not addiction, but it does mean that the body needs some time to wind down its familiarity and dependence, physical dependence. And so usually a gradual down titration of about 10 to 20% of the dose per week will avoid withdrawal symptoms. Next slide. Now, in Australia, we have a number of opioids that we can use, and occasionally patients will be changed from one opioid to another if they are not getting a good outcome with the opioid that we started. There are individual differences in the way people respond to opioids. Some people also may have more side effects with one type of opioid than with another, and so we switch. And we have access to a number of opioid conversion charts. I didn't think it was worth spending a lot of time talking about this for the Bhutan context, but I guess it's just something to be aware of. And it raises that, it relates to that question about fentanyl earlier, that there may be times when it's indicated to move from morphine to fentanyl. For example, we do know that fentanyl is less constipating. And so if someone's really having trouble with morphine-induced constipation, then that could be a reason to consider fentanyl. Next slide. And fentanyl is a lot more potent than morphine. It's safe in renal failure and it's less constipating. In Bhutan, you only have the 50 microgram patch, as far as I could see. So that equals roughly 1,200. So that equals roughly 150 milligrams. No, I'm getting that wrong. I think around about 100 milligrams of morphine over 24 hours. I should check something like that. So it's quite a high dose. So you wouldn't start a patient on a 50 microgram per hour patch, but if they were on a highish dose of morphine and having problems, that might be an option. Or if they were no longer able to take things by mouth, it could be an option. And you can actually use more than one patch at a time. So you could have a patient on 100 micrograms of fentanyl by putting 2 patches on. Next slide. So adjuvants is a word to describe drugs that don't have an intrinsic analgesic effect, but are able to target the mechanism of the pain in some specific way. For example, dexamethasone may reduce raised intracranial pressure and give pain relief that way, or baclofen might relieve muscle spasm and pain associated. They are useful because they do help to limit the opioid dose, and sometimes they're just much more effective than the opioids are on that particular type of pain. And many are quite neuropathic pain specific. So the 2 classes of drugs there are the anticonvulsants and the antidepressants that we use quite often for neuropathic pain. Next slide. I'll switch over to the next slide as well. Thanks, Sangeet. So this was a recent update published a couple of years ago by a group in England, where they tried to review the literature and summarize what we have strong evidence for and what we're not really sure about yet. So it could be a useful article to be aware of. But as I said earlier, lack of evidence doesn't mean necessarily lack of effect. And we still often need to try an agent that could potentially have an effect and see the end of one trial for that patient as to how it will actually benefit or otherwise. Next slide. And some take-home messages. So we believe the patient and form relationship, address the underlying cause of the pain, use non-pharmacological strategies, know the pharmacokinetics of the medicines we're using and use them to their maximum efficacy. Remember the WHO guidelines and use adjuvants to be opioid sparing and targeting neuropathic pain mechanisms. Next slide. So I thought I'd mention this course because it's been run in a number of countries now. It was developed by a couple of anaesthetists from Australia and New Zealand called the Essential Pain Management. And it includes a kind of train the trainer model. So it could be something that might be of interest to look at for Bhutan. And they use this little mnemonic of RAT, hence the picture of the rat. So recognize, assess, and treat. And they then go through a very case-based kind of approach to teaching pain management. And then I think the last slide is just a few resources. Next slide. Okay, so thank you all very much.
Thank you very much, Odette. What an amazing topic and what an important session on pain assessment and pain management. I'm sure our participants here often have been struggling on how to assess first and then how to manage, So I'm sure there's so much to take from these 2 lectures, and the most important take-home message I would personally take is believe the patient and form the relation. Things works from there, I feel. And before we proceed, there are a couple of questions here. There's one question: is it wise to manage pain in a ventilated patient with analgesics around the clock, or just assuming that he has pain, or anticipate that the patient will experience pain? And so how do we go about with that?
That's a great question, and I confess to ignorance in ICU pain management, but I think Melanie, please jump in if you have more to offer there. But I think certainly a lot of patients in an intensive care setting will have, you know, at least we can imagine significant pain or syndromes that are likely to be causing significant pain. And I guess the physiological parameters are what the intensivists would go by, and they would generally be using analgesia as part of the whole care. Melanie, do you have more experience on that?
Yeah, I think the only thing to add would be if someone's post-operative, then there's similar requirements that they would have, you know, if they weren't in intensive care, would be what you would expect. I think the other thing to remember for someone who's in intensive care or who is having surgery, if they are already on an opioid prior to coming in, then they will need to continue to have that opioid as their baseline, plus any post-operative requirements that they may have. So if someone is already on 30 milligrams of morphine and they have a hip fracture repaired, then they will need additional opioids for the post-operative period. The other comment I'd just make is just to echo Odette's point about the fentanyl patch. If it's a 50 microgram patch, as Odette said, 150 milligrams of morphine. So people will need to be on a reasonable dose. And often when we're converting from one type of opioid to another, we'll dose reduce because they'll get a more beneficial effect from a lower equivalent dose. So if you are going to convert to someone to a fentanyl patch, they will need to be on more than 150 milligrams of oral morphine. The other thing just to mention is that if people are using parenteral morphine, then usually it's about half to a third of the oral dose equivalent. So 150 milligrams of morphine orally will be about the same as 75 to 50 milligrams of subcutaneous or intravenous morphine.
Thank you. And there's one more question. What strategies were used in Australia to make opioids, especially morphine, available at the primary health care level? And that's one area where I'm also thinking about how to make it available, because at the moment, our morphine goes till district hospitals and the primary health centers. Of course, there are no doctors at the primary health centers. It's run by primary healthcare providers. And we do not have morphine. So there they only have paracetamol or ibuprofen. And how to, that is one area I'm interested as well in making morphine available at the primary health center, because our patients ultimately goes back to the community, and only to get morphine, they would have to, you know, struggle to come to a district hospital to collect. So thank you, Dr. Namka, but please help us how Australia dealt with it.
And just on that too, Tara and colleagues, how, if the patient leaves the district hospital and goes home, how much supply of opioid morphine, for example, can they take with them?
Well, I could be wrong, but at least for a month, I feel. If anyone would want to jump up, please just let us know. But I feel at least for a month, morphine stock is being given. But at times, you know.
And sorry, and do they need to come back for the next prescription, or can family members come back for that? For them?
Normally, the family members can come back. If the patient cannot, family members can come. But there are also lots of other obstacles that happens due to, you know, monsoons and so those were some of the points raised by my study participants as well, that having morphine supplied till the primary health center could help. But we need to really get evidence. We need to get help. We need to make people understand, including the policymakers and everyone. But I feel that would be very important and useful.
Yeah, I think so. And I mean, you have a tiered system of healthcare from the tertiary hospitals, district hospitals, and then centres. So I think that's a common challenge for many countries, is getting morphine to be available and accessible to patients where they are. But if you can, if the patient can get a 1 month supply, that's actually a lot better than in many places. Some places they can only get for 3 days supply at a time, or the variability across the world on this is kind of both irrational and highly problematic. I mean, there has to probably be some local sort of consideration, because there are you need good governance to have safe opioid supply. And if you haven't got good governance, if the country really is struggling with its health resources, then it can be dangerous, because you don't want to have too many gaps that will allow diversion or misuse. So there are a lot of checks and balances to try and get in place, but I guess we're coming from the perspective that we really want to ensure patients have access to essential medicines, and it's regarded internationally at all the high level agencies, that opioids, controlled medicines are essential and so I think we have to call our policymakers to challenge to how can we make this. Water is essential, and we do everything we can to make sure that water is available. Well, if we use the terminology that it's essential, then that has ramifications. So good luck.
Yeah.
And I mean, there are agencies like the UNODC and WHO and so on are really working very hard to try and improve this situation globally. So.
And I think one avenue is definitely such education sections and forums where we could help others understand as well.
That's
so
right.
yeah.
Because unless there's demand, and unless prescribers feel comfortable with prescribing, and patients understand that it's a good thing to have access to, then even if you do put the policies and medicines available, if it's not being prescribed and it's not being used, then
right. Yeah. Yeah, there's, if someone could help answer a question there in the chat. And in the meantime, I would like to invite Sister Young Den with her case presentation. Sangeet, would you mind sharing the slides for case presentation, please? There's someone asking.
The screen share from my end.
You can do that if you want. You want to do that? Okay, good. Thank you.
Okay, I'm disabled too.
Yeah, I have enabled now.
Okay.
Yeah, that screen is visible. Thank you.
So good afternoon, everyone. I'm Young Den. I'm a clinical nurse. I work at the National Referral Hospital in the palliative care unit. So for today, for today's case presentation, we have a 57-year-old lady. She has been diagnosed with recurrent carcinoma of vulva and anal canal. And at the outset, I would like to say that this lady had been diagnosed with cancer in 1997. Since then, she has been it has been a long battle for her. She was cured. In between, she had to go the vigorous chemotherapy and radiotherapy. Again, she got cured, and again, there was recurrence. So it has been a really long battle for her. And to add to the suffering, in the process of the treatment, she has lost her hearing ability as well. And she has also lost her original medical documents. So what I present here today would be some information that I got from the patient's daughter and few of the doctor's notes available with her. So, okay. This is prepared as per the template provided by the organizer. So first, the presenting complaints. This patient has pain at the perineum, which is stinging, burning, and throbbing in nature. And the pain radiates to the lower back and the front of the pelvis. She has difficulty in sitting properly, and she has difficulty sleeping at night. And she has this difficulty in passing stool. As per the daughter, this patient was advised for a colostomy back in 2018, but she and the family had refused for colostomy, and she still doesn't have a colostomy. With regard to the history of illness, she is a known case of diabetes, and she is on metformin for that, and also a case of hypertension, and she is on losartan. And somewhere in the note, I also saw that she is also a case of bronchial asthma, but then I didn't see any medication prescribed for that, so I didn't note it here. The history began in 1997. She was referred to one of the private hospitals in Kolkata for a surgery and a chemotherapy. And then after, I think she was cured, then she got the recurrence of the disease again in 2011. And from 2011 to 2018, she was being treated at the Christian Medical College Hospital in Vellore, that is in South India, for her recurrent carcinoma of vulva. And that time she also had that growth in the anal canal, and which turned out to be again early invasive squamous cell carcinoma of the anal canal. And as per the daughter, she said that she had, at that time, she was just a young teenager, so she had accompanied her mother to the CMC Vellore for 9-10 times. After that, again, in early 2023, she had again bleeding from the rectum, and at that time, she was being assessed by our onco-gynae surgeon here at our hospital, and then was referred to Tata Medical Center in Kolkata. And there they had started her own palliative chemotherapy, and she was sent back to Bhutan. And in September, we got a call from one of our nurse colleague, and then we registered her for home care service. The examination findings for her is like, she has a pain score of 7 to 10 on most of our home visits, but there were a few occasions when she was pain-free as well. And with a Cox scoring of like 2, that is being capable of self-care, but she is not able to carry out any other household chores. And she's up and about more than 50% of the waking hours. And her vital signs had remained within normal range in all of our home visits. And she has that open lesion, fungating wound in both her vulvar and anal region. And that there is a very unpleasant odor from the wound and also from the PV discharge. And she is on suprapubic catheter. And when I asked when from when she was on that, the daughter said that she was on suprapubic catheter since 2018. And she, as I mentioned earlier, she has lost her hearing ability. She is completely deaf now because of the treatment processes. And it has been difficult for us to obtain a proper history as well. Treatment and significant investigation. In 1997, she had this radical valvectomy with bilateral ilioinguinal dissection at a private hospital in Kolkata. And then she had the recurrence in 2011-12, and with a growth in the anal canal. And that turned out to be, the biopsy turned out to be squamous cell carcinoma of the anal canal. And she was advised for chemotherapy, which was combination of paclitaxel and carboplatin. She had completed 6 cycles of chemo, and I think she was better after that. But again, in 2014, the disease recurred, and the PET-CT done that time showed that metabolically active pelvis lymph node. At that time, chemotherapy was advised, but again, here patient didn't want to undergo chemotherapy. And in 2015, there was soft tissue thickening in the left vulva and anal canal. And for that, she had to again undergo radiotherapy. In 2019, she had her CT abdomen done in our hospital, which revealed ill-defined irregular enhancing lesion, which was noted in the vulval region, and it was measuring approximately 3.6 to 3.2 centimeter. And the latest investigation she had was in early 2023, where she had an MRI pelvis, and that time also there was a large enhancing mass, which was located mainly in the region of right side of the vulvar side. And it was suggestive of locally advanced vulvar cancer, and it was recurrence. And in early 2023, she had this bleeding from rectum, and that time she was assessed here and was being referred to Tata Medical Center in Kolkata. And that time she was given a combination of injection nanoxyl and injection carboplatin, and with palliative intent that time. So then she completed her chemotherapy here in our hospital. With regard to psychosocial aspects, this patient has very complex family dynamics. She has been separated from her husband very long time back. The daughter said she was a toddler when her parent got separated. And the only child she has is that daughter, who is now married and has a child and lives with her husband and her in-laws. And the only person that is around the patient is her 77-year-old mother. And right now, two of them are not in talking terms. And when I asked the daughter that how supportive the grandmother is, then she mentioned that the grandmother was the only one who took care of the mother throughout, and was also assisting the mother with the finances and other support. And as I talked earlier, she has complete hearing loss, and this leads to communication challenge, and which results in non-compliance to medication and adherence to our instructions. And because of the duration of the disease, illness, and the nature of the disease, and that foul smell associated with that condition, that has led her to social isolation. And most of this time when we go to visit her, she's all alone. The medications she's on are, we have given her morphine, both sustained release and immediate release, and paracetamol, and combined with amitriptyline HS and gabapentin. And during our visit, when she's in acute pain, sometimes we also had to inject her injection diclofenac. And for laxatives, we have given her combination of tablet senna and syrup lactulose. And sometimes we had also inserted that glycerin suppository for her. And for her, the fungating wound, we have, she's been doing cis bath morning and evening. And then for that bad odor, we have given her metronidazole powder and solution. And she's on losartan and metformin for her diabetes and hypertension. So the main concerns for this patient is pain and this difficulty in passing stool. These are the two major symptoms she's facing right now. And and the problem with her is like she has not been able to is not taking the medication like around the clock. Maybe she's not able to follow us. And the other apparent issue is like caregiver stress. We have seen that I think they have both the mother and daughter has been experiencing extreme fatigue, and we have not been able to communicate with her to telephone like other patients. When we for other patients, it's always the patient that we want to talk to, and we have been talking to patients, not with the families. But for this particular patient, it has like the only person we can contact is the daughter, and who is not living with the mother. So face-to-face communication it is through face-to-face communication that she talks to us, reading our lips. And the summary is like, this is a 57-year-old woman with recurrent carcinoma of vulva and anal canal, and on palliative care. And the main concern has been inadequate pain management for her, and ineffective communication and caregiver stress. And And the discussion points would be like, how do we achieve educate pain management, and how can we make the patient adhere to medication around the clock, and how can we achieve effective communication with her condition. And one area which is lacking is caregiver support and counseling for this patient and her family. And that's it. Thank you.
Thank you, Sister Youngden. I'm almost breaking down, but it's such an overwhelming. Thank you so much indeed for bringing this overwhelming, I know I at times feel it is not as, patient, human beings do not suffer to that extent, but we do, right? And I felt it is beyond total pain. It is beyond total pain. And we are running out of time, but I think we would, I would request Odette and Melanie to help us. How would you, take care of this patient if it was in your practice? I think we will start from there.
Shall I go first with a comment, Melanie? Look, just a wonderful, I know it's a distressing case, but a wonderful case to bring up. Thank you, and you did a beautiful job. And I'm sorry we don't have a little bit more time to discuss it. I don't know whether we can stretch a little bit for another 5 minutes, but I know everyone's busy. I think it reminds me of that when I talked last week about how pain can be the situation can be overwhelming for us as healthcare providers. And that can, I noticed the comment in the chat, that can lead us to a sort of sense of desperation and despair. But it's helpful to, think of that model of total pain and break it down into component parts and look at each part, the physical, the psychological, the social, the spiritual, and what can we address in each of those areas, and try to, chipping away at total pain where we can make a big difference. And that also helps us to feel a little bit less helpless and a bit more useful. So, I mean, I think there's room to move with her analgesia. She is certainly not on maximum opioid. And if she's not using the breakthrough, maybe you could use that percentage model to increase her opioid. She could have more of the adjuvant also, the amitriptyline. There could be other strategies that you might look at specifically for her pain. The reducing infection would also help with the odor, and that would also help with her psychological well-being, I would think. You've talked so beautifully about the caregiver stress, and you can only imagine what it must be like after all those years for that couple to kind of sustain themselves in the middle of all of this. Maybe I'll stop there and I'm sure Melanie's got some further points she'd like to make, but there's lots to discuss.
Thank you, Odette, and thank you, Youngden. What a important case to illustrate the wide range of issues that impact on someone's pain experience. Even just the isolation and the shame that goes with having that offensive or malodorous discharge can make a huge difference. And so your management of that with sitz baths and the metronidazole gel, and there are other potential ways of adding to that with aromatherapies or essential oils, that sort of thing. That will be a very important step. I think we mustn't underestimate the benefit of compassion, and you'll evidently be demonstrating that every time that you see her. I have understood that she has difficulty hearing. I'm not sure how much she's able to say or whether she's got literacy and can read. In terms, oh, sorry, go on. You're going to answer that?
Yeah, she is not literate. She cannot read and write, but she can speak. She can express all her concerns to us. But when we speak to her, we have to like remove our marks and speak so that she can read our lips. Then sometimes, most times she gets correctly, but sometimes she misses what we are trying to say.
Yeah,
She
of course. And I was wondering about the financial issues as well. She's on a lot of medications, which I imagine are expensive, and whether that's impacting her adherence to medication or not. I'm not sure if I've got any pharmacists online, but sometimes putting medications into, we call it a Webster pack, but it's a medication pack where it's very clear what medications you take at what time of day. It might be just a plastic container where you flip open the medications and it's got the name of the days on it so that she knows that she takes this medication in the morning and this in the afternoon and this if she's got extra pain. It's such a good case to illustrate how important the communication is, and for her to sort of understand what is happening must be very complex. It's also a really good case because she's had this long history since 1997 of intermittent pain, which will have at times been poorly controlled, at times well controlled. So all that will be playing in. I think the only other comment to make is if there's anything that can be done to address those multiple issues that you mentioned that can be impacting her threshold. She may well be quite depressed. I know she's on a low dose of amitriptyline, but I imagine it would be very understandable if she was depressed. So considering depression management and lots of listening from you and the team. I think they're my main suggestions, and I agree with all the suggestions that Odette made about the potential adjustments in medication.
I was also thank you, Melanie, and thank you, Odette, for helping us with that. And I was also thinking, is any way spiritual leaders involved there, or are they interested to be associated with spiritual leaders, Sister Youngden?
Yeah, we couldn't initiate this conversation with the patient, and like I mentioned, she's most of the time all alone. So maybe if we talk to the daughter, she may maybe interested, but we have not offered them this. And thank you, Melina and Dr. Odette, for the supplementing.
Sorry,
And,
yeah.
Sorry to interrupt. Is it okay? I mean, I'm sure Melanie and I would be happy to continue the conversation on email if you have any queries about her management down the track. But I don't know if her doctor or medical team are part of the call, maybe. Are they still involved? Does she still have a medical team involved?
We do not have a doctor in the team right now, but she was supposed to meet her gynae-onco surgeon today. I do not know whether they met or not. I have not followed up on today. So, but as a part of home care team, we do not have a doctor. It's just a team of nurses.
And I guess that's one of the dangers too, is kind of ongoing in treatment that may not be oncologically directed treatment that may not be helping her with her symptoms. There is a danger of over treatment with these patients as well, which adds to their suffering.
Yeah, and in the team here, in the participants team, we also have an audiologist, actually the only audiologist in the country, if I'm not mistaken. And she is asking, did she get any sort of audiological evaluation to assess her hearing? So we might request Nima to join and make an assessment, help her get assessed, or she may be brought to the hospital. We may work out. And I was also thinking if we can communicate with the daughter, and if they're interested, maybe arrange a spiritual person to, help them as well. So just looking at all this holistic approach of how to improve the situation, improve the quality of life of all of them, the patient and the family as well. And I hope I didn't miss any important questions here in the chat. I was saying, like, patients normally do not buy medicines here. Most of the medicines are free. In fact, all medicines are free, all healthcare is free, referral is free, all borne by the government. And I'm also told we also have named patient system. Yeah, so we also, even if the medicines are not in the list, there's certain way of providing free medications to the patient. That way we are very, very fortunate. Thank you, Jiangchu. And Beam is saying it's difficult to communicate with both hearing and sight loss patient after chemotherapy. If he or she is literate, then how do we communicate? So I think we will have to explore around all those. And being mindful of the time, I think we will try to bring the session to a close. And for that, I would once again would like to thank, on behalf of all the participants here, thank you, Odette, thank you, Melanie, and Sister Young Den, for really, really important session. And I think we feel much, much more better, much, much more confident in dealing with pain and helping address pain in our patients. And with that, thank you very much. If there's anything important, if anyone would say otherwise, we will bring the session to a close. Thank you. See you next week.
Thank you,
Bye,
Odette.
everyone.
Thank you, Melanie, for the wonderful presentation. And thank you, Sister Yang Team, for the case presentation as well. Thank you, Tara, for facilitating this session.
Thank you, Sangeet.
Thank you, everyone, for joining and participating and making it an active sessions. Thank you. See you in the next sessions. Thank you. Bye.
Thank
Thank
you
you
for
so
being
much.
there
See you
for
next
us.
week.